Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, you're probably looking at this image and have already found the lesion on this patient's left nostril. How astute of you. We're going to be discussing this and much more in this presentation on skin pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material. Now, skin pathology. The skin, as we know, serves as a defense against fluid loss and environmental irritants. The skin is made up of a dermis and an epidermis. The epidermis is composed of keratinocytes and has 5 layers that you should know about: basale, spinosum, granulosum, lucidum, and corneum. The regenerative stem cell layer is found in the stratum basalis. The stratum spinosum is also distinguished by desmosomes between keratinocytes. The stratum granulosum is distinguished by granules in keratinocytes. The stratum corneum is distinguished by keratin in anucleate cells. The dermis is made up of connective tissue, nerve endings, blood and lymphatic arteries, and adnexal structures such as hair shafts, sweat glands, and sebaceous glands. And here to the right, we have a skin biopsy showcasing specific pathology. In this case, it's tinea, right? We're going to be getting into the diagnosis of many different skin conditions that you need to know about, starting with inflammatory dermatoses, such as atopic dermatitis. Atopic dermatitis is also known as eczema. As you can see here, with this atopy of the flexure crease of the elbow. An itchy, erythematous, oozing rash with vesicles and edema is present in atopic dermatitis. Atopic dermatitis frequently affects the flexure and facial surfaces. Asthma and allergic rhinitis are connected with a type 1 hypersensitivity reaction and are commonly found in patients with atopic dermatitis. And here we see a cartoon illustrating the various locations of the lesions associated with atopic dermatitis through the progression of life from infant to older child to mid-teens. Now, contact dermatitis. A pruritic, erythematous, oozing rash with vesicles and edema is a hallmark of contact dermatitis. To the right here, we can see a picture of a patient that has a healing rug burn and contact dermatitis around it. Contact dermatitis is caused by the skin coming into contact with an allergen or irritant, such as nickel jewelry, poison ivy, irritant chemicals, or penicillin. Treatment of contact dermatitis includes removing the offending agent and topical glucocorticoids if necessary. Here's an image of contact dermatitis caused by unprotected handling of damp, impregnated wooden construction debris. Watch what you're picking up out there. And here we have a 3-year-old girl with contact dermatitis one day after contact with poison ivy. And here we have contact dermatitis patch test. Now acne. You'll see this a lot. Acne vulgaris is characterized by the presence of nodules, pustules, and comedones, such as whiteheads and blackheads. Acne vulgaris can be caused by persistent inflammation of the sebaceous glands and hair follicles. They are exceedingly frequent, especially in adolescents. Hormone-associated increase in sebum production, where sebaceous glands have androgen receptors, and excess keratin production block follicles, forming comedones. Infection with Propionibacterium acnes results in the production of lipases, which degrade sebum and release pro-inflammatory fatty acids, causing pustule or nodule growth. Acne vulgaris can be treated with benzoyl peroxide and antibacterial, and vitamin A compounds like isotretinoin that lowers keratin synthesis. Here we have a picture of a patient with nodular acne, and nodular acne on the back we can see. Here is some benzoyl peroxide cream used to treat acne, vulgaris specifically, and a flowchart of the pathological sequence of events leading to acne. And various different cartoons showcasing the representative formation of acne comedones. Note the whitehead, blackhead, pustule, cyst, papule, and nodule. And another cartoon showcasing the difference between a normal pore, a whitehead, and a blackhead. Now psoriasis. Psoriasis is characterized by well-circumscribed salmon-colored plaques with silvery scales on extensor surfaces and the scalp. Nail pitting may also be evident in psoriasis. Make sure you do a thorough examination. Psoriasis is due to excessive keratinocyte proliferation. And there is possibly an autoimmune etiology of psoriasis associated with HLA-C. Psoriasis is associated with an environmental trigger. Traumatized skin areas frequently have psoriasis lesions in patients with this condition. The histology of psoriasis includes acantholysis or epidermal hyperplasia, hyperkeratosis, parakeratosis, i.e. retention of keratinocyte nuclei in the stratum corneum, and the Auspitz sign as well. By the way, the Auspitz sign is when scale is picked off, neutrophils in the stratum corneum, and thinning of the epidermis above the elongated dermal papilla cause bleeding. Now, how do you treat psoriasis? Well, psoriasis is treated with corticosteroids, ultraviolet light with psoralen, and immune modulating therapy. Here we have a psoriatic plaque showing a silvery center surrounded by a reddened erythematous border. And here we have histology of psoriasis. Note the confluent parakeratosis and the psoriform epidermal hyperplasia. And more psoriasis, this time on the back of a patient. And a picture showing the effects of psoriasis on the toenails. And here we have the nail pitting associated with psoriasis in some patients. And an example of Gutate's psoriasis on a patient's back. And even on the palms of the hands. And here we have a person's arm covered with plaque psoriasis. And here we have a Munro microabscess, which is present in psoriasis. Now, Lichen Planus. Periodic, planar, polygonal, purple papules, the 5 P's of Lichen Planus. Periodic, planar, polygonal, purple papules with reticular, while lines on their surface describe Lichen Planus. Lichen Planus most usually affects the wrists, elbows, and oral mucosa. Oral involvement in Lichen Planus manifests as Wickham striae. Histology, right, for you pathologists out there, future pathologists, the histology of Lichen Planus shows inflammation of the dermal epidermal junction with a sawtooth appearance. Although the etiology of Lichen Planus is unknown, it is found to be associated with chronic Hepatitis C virus. Remember that, because you might be asked. It's Hepatitis C virus infection. Here we have histopathology of Lichen Planus. Note the loss of the basal cells and the interface dermatitis, i.e. those lymphocytic infiltrates present at the dermal epidermal junction. And here we have the classic white striations of non-erosive Lichen Planus of the left buccal mucosa. And more Lichen Planus, this time on the tongue. And look at that nail pitting. Now this is nail pitting associated with Lichen Planus. And also, there are these cutaneous Lichen Planus lesions on the skin and on the lower lip and on the legs, the shins. Now more histology, showcasing interface dermatitis, that's important, with Lichen Planus. Now let's talk about something that's very, very, very important. You're going to see this a lot, so listen up close. Blistering dermatosis. We have to talk about Pemphigus vulgaris, PV. Now, Pemphigus vulgaris is the autoimmune destruction of desmosomes between keratinocytes caused by an antibody against desmoglin type 1 that manifests as skin and oral mucosa. Bullae. Got that? So it's against desmoglin. It's a type 1 hypersensitivity reaction, I should say, that manifests as skin and oral mucosa bullae. To the right here, we can see H&E showcasing Pemphigus vulgaris. Pemphigus vulgaris is characterized by suprabasilar blisters caused by acantholysis or the separation of stratum spinosum keratinocytes that are ordinarily united, held together by desmosomes. Hemidesmosomes keep basal layer cells connected to the basement membrane. Shallow erosions and dry crust result from rapidly rupturing thin-walled bullae. In Pemphigus vulgaris, IgG surrounds keratinocytes in a buzzword, fishnet-like pattern during immunofluorescence. Here we have a patient with Pemphigus vulgaris, and as you can tell, it has a positive Nikolsky sign. Here we have histology of Pemphigus vulgaris. In A, we can see the intraepidermal blister in row of tombstoning. And in B, we can see the eosinophils and a few neutrophils present within the blister. Now, bullous pemphigoid. Bullous pemphigoid is an autoimmune destruction of hemidesmosomes between basal cells and the underlying basement membrane due to IgG antibody against basement membrane collagen. Bullous pemphigoid presents as blisters of the skin, and oral mucosa is spared. Here we have an image showcasing H&E and immunofluorescence of bullous pemphigoid. I'd like to draw your eyes to panel B. Note that there is a linear deposition of IgG in the basement membrane. That's important to know. And here we have a picture of a patient's leg showcasing bullous pemphigoid. Now, dermatitis herpetiformis. What's that? Well, IgA is deposited by the immune system at the ends of dermal papillae in dermatitis herpetiformis. To the right here, we can see the characteristic rash that somewhat resembles herpes and is the basis of its clinical name, dermatitis herpetiformis. Dermatitis herpetiformis lesions appear as clusters of pruritic vesicles and bullae. Celiac disease has a high correlation with dermatitis herpetiformis and can be treated with a gluten-free diet. In this condition, the basal cell layer is detached from the basement membrane. Tense bullae of dermatitis herpetiformis are clinically less severe than Pemphigus vulgaris and do not rupture easily. Immunofluorescence of dermatitis herpetiformis shows IgG along the basement membrane in a linear pattern. Here we have a picture of a patient with confluence of dermatitis herpetiformis lesions on the abdomen. And here we have a cartoon showcasing gut-skin pathophysiology associated with dermatitis herpetiformis. And an H&E micrograph of dermatitis herpetiformis. Note the subepidermal vesicles with papillary neutrophil microabscesses. And here we have dermatitis herpetiformis. Note the subepidermal bullae in A, and on B, the direct immunofluorescence showing granular deposits of IgA along the dermal papilla. Now let's talk about another important condition, erythema multiforme. Targetoid rash and bullae are the hallmarks of the hypersensitive reaction known as erythema multiforme. To the right here, we can see a picture of a patient's hand with erythema multiforme. The targetoid appearance of erythema multiforme is caused by erythema surrounding a core epidermal necrosis. The most common causes of erythema multiforme include herpes simplex virus infection, mycoplasma infection, medications like penicillin and sulfonamides. Autoimmune disorders can cause erythema multiforme, as well as malignancies. Here we have a picture showcasing a somewhat targetoid lesion in a patient with erythema multiforme. And here we have multiple lesions on a patient's leg of our erythema multiforme. And even the tongue and oral mucosa affected by erythema multiforme. And here we have a skin picture of the histology showcasing lymphocytic infiltration in the upper dermis with papillary edema and vacuolar change in the basal cell layer and necrotic keratinocytes within the epidermis in this patient with neonatal erythema multiforme. Now let's talk about another very important condition. You'll definitely see this. Stevens-Johnson syndrome. Stevens-Johnson syndrome, SJS, is characterized by erythema multiforme with oral mucosa/lip involvement, fever, and skin sloughing. To the right here, we can see a very high magnification micrograph of confluent epidermal necrosis. This can be associated with SJS or TENS, this histology specifically. Stevens-Johnson syndrome is like TENS, toxic epidermal necrolysis. Stevens-Johnson syndrome is less than 30% body surface area involvement. And toxic epidermal necrolysis is a severe variant of SJS, as you can see here on this patient's back. Toxic epidermal necrolysis is greater than 30% body surface area involvement. You have to know that number. The most frequent cause of toxic epidermal necrolysis is medication. Now let's discuss the epithelial tumors, starting with seborrheic keratosis or seborrheic keratosis. Now SK is a benign squamous proliferation that is thought to be a typical tumor in elderly people, as you can see here to the right on an elderly patient's back with numerous seborrheic keratoses. This actually is the lesser Trellat sign that is associated with colon cancer. Seborrheic keratosis typically appears as elevated, discolored plaques with a coin-like, waxy, stuck-on appearance on the extremities or face. Seborrheic keratosis exhibits the histological feature of keratin pseudocysts. To the right here is a great example of seborrheic keratosis. Note the basaloid cells mixed with the squamous cells and the keratin-filled invaginations of the epithelium. Note the intraepidermal horn cysts and the brown globule-like structures composed of melanocytes found at the dermal-epidermal junction. Like we saw earlier, the lesser Trellat sign, which is the abrupt emergence of numerous seborrheic keratoses, signals underlying gastrointestinal malignancy. To the right here, we can see an inverted follicular keratosis. Now, acantholysis nigricans. What is that? Acantholysis nigricans is a condition where there is epidermal hyperplasia and skin darkening that frequently affects the axilla, right, the armpits, or groin. Acantholysis nigricans is linked to malignancies, particularly gastric cancer or insulin resistance, such as non-insulin dependent diabetes. Here we have a picture of a patient, a young patient, with an 8-year history of acantholysis nigricans. This is a very atypical presentation for acantholysis nigricans. This is some epidermolytic hyperkeratosis. Yeah, this is a very different presentation. Very different. Now, this is the histology associated with acantholysis nigricans. And this particular patient had squamous cell carcinoma of the lung presenting with paraneoplastic type acantholysis nigricans. Now, basal cell carcinoma. You'll have to be able to recognize this. You'll see this a lot in multiple settings. Basal cell carcinoma is the malignant proliferation of the basal cells of the epidermis. As you can see here to the right, this is a picture from a patient's back. Now, basal cell carcinoma is the most common type of skin cancer. Basal cell carcinoma is the most common cutaneous malignancy. Long-term sun exposure, albinism, and xeroderma pigmentosum are risk factors that result from DNA damage caused by UVB radiation. Basal cell carcinoma, BCC, commonly appear as a raised nodule with a pink pearl-like papule in the center and dilated telangiectatic vessels surrounding it. Basal cell carcinoma is classically located on the upper lip. Basal cell nodules with peripheral palisading are visible in histology. Basal cell carcinoma rarely metastasizes, and basal cell carcinoma is treated by surgical excision. You remember this picture? Yes, ulcerated basal cell carcinoma affecting the skin of the nose of our patient. And here is what it looks like histologically in certain cases. This is a micrograph showing basal cell carcinoma with the characteristic histomorphologic features. Note the peripheral palisading, myxoid stroma, and artifactual clefting. And here we can see utilizing a dermoscopy of an approximately 16 millimeter nodular basal cell carcinoma showing telangiectatic vessels. And here we have a basal cell carcinoma, nodular and micronodular, marked on the back of a patient. And here we have high-risk basal cell carcinoma on the person's ear. Wow. You future doctors out there that will be performing surgeries, hats off to you. And here we have a picture showcasing the microscopy of nodular basal cell carcinoma. And superficial basal cell carcinoma histopathology. Note the basaloid tumor cells and the white arrow pointing to the lichenoid response. Now, squamous cell carcinoma. Yeah, you'll see this a lot. Squamous cell carcinoma is a malignant proliferation of squamous cells characterized by formation of keratin pearls. Risk factors for squamous cell carcinoma include prolonged sun exposure, use of tanning beds, immunosuppressive medications, exposure to arsenic, and chronic inflammatory conditions, including burn scars or nasal drainage. Squamous cell carcinoma typically manifests as a nodular, ulcerated mass on the face, typically involving the lower lip. Treatment of SCC, of squamous cell carcinoma, is surgical excision. And you want to be sure to make sure the margins are clear, right? And here we have histology, which you need to be aware of for squamous cell carcinoma. Note that this is a highly differentiated squamous cell carcinoma of the mouth. You have the typical squamous cell carcinoma cells in the large, abundant eosinophilic cytoplasm, right? You can see that. And here we have clear cell squamous cell carcinoma. And here, some of the main histologic features associated with squamous cell carcinoma. This one in particular is of the bladder, but you want to see these features in the skin as well, particularly the keratinization, eosinophilic cytoplasm, and the intracellular, intercellular bridges. Like this in the skin. Now this is a spindle cell squamous cell carcinoma. So not what you would classically see, right? It's a little spindly. And this is a basaloid squamous cell carcinoma, right? Right. This is not what you would typically see, but you need to have it on the differential. But for your purposes, at your level, if you are a medical student, right? This is all esoteric fodder for future pathologists and dermatologists and dermatopathologists, plastic surgeons, right? So at the medical school level, just tuck this away. Okay, now you do need to recognize these pearl-like lesions, right? This is adenoid squamous cell carcinoma. And this is a picture of squamous cell carcinoma that was taken with a paper bag. Now, actinic keratosis. Actinic keratosis is a precancerous lesion that frequently develops on the face, back, or neck and manifests as a hyperkeratotic scaly plaque. To the right here is a great image of that. And a keratoacanthoma, right? A keratoacanthoma is a benign epithelial tumor with squamous elements. So make sure you can tell the difference between this and squamous cell carcinoma. They'll try to trick you, but you won't fall for it. Because you know that while a keratoacanthoma develops quickly and spontaneously regresses, it is a well-differentiated squamous cell carcinoma that looks like a cup-shaped tumor loaded with keratin debris. Now this is a big deal. Melanocytic disorders. All you future dermatologists out there, I see you smiling. Melanocytes are responsible for skin pigmentation and are present in the basal layer of the epidermis. Melanocytes are derived from the neural crest. Melanocytes synthesize, as you know, melanin in melanosomes using tyrosine as a precursor molecule to pass melatonin to keratinocytes. Now, this is important. I want you to pay attention to these slides. Normally, you know, the slides that aren't important, I'll just kind of hint at them or let you know, but this is very important. You need to make sure you recognize this. A, B, C, D rule. If you haven't heard it before, you're hearing it now. You need to go through this. So on the left side, from top to bottom, we have melanomas showing asymmetry, right? And then B for border, C for coloring, and D for diameter. And actually, there's an E. that's not here, but I'll tell you now. Come here. Shh. E is for evolving. If the lesion's getting bigger, it's a bad sign. It means it's probably melanoma. So, asymmetry, border, coloring, diameter, whether it is a big or small, and evolving. I'm not going to keep a secret from any of you. I want you all to succeed, right? That's what I'm here for. I'm doing my part of the job. You make sure you do yours, right? You get out there. You don't disappoint me. I'm proud of you. So, where was I? Asymmetry. If the lesion's asymmetric, it's probably melanoma. You can just, for testing purposes. If the border is weird, like the ones on the left, it's probably melanoma. If the coloring is various, it's probably melanoma, like the one in the left column. And if the diameter is changed in size or it's large, more so changed, then it's probably melanoma, all right? And that ties into evolving too. If it's changing very rapidly, it looks different, it's probably melanoma, okay? Now this is a lymph node with almost complete replacement by metastatic melanoma. The brown pigment is the focal deposition of melanin, right? You see that? And you see this? You see any normal lymphocytes? Maybe to the far right. Other than that, this thing's packed with melanocytes. Bad melanocytes. Now let's talk about the melanocytic disorders, such as vitiligo, right? You've seen this, you've heard about this, you know this. Vitiligo, right? What causes that? Well, the autoimmune death of melanocytes causes vitiligo. Vitiligo is characterized by localized loss of skin pigmentation. And here's a well-known figure in certain circles who has vitiligo. And you'll probably see this with a wood lamp showcasing vitiligo. Not like you can't see that without the wood lamp, right? Am I right? And here we have vitiligo on a person with lighter complexion. And here we have vitiligo on a person with darker complexion. Should we get our wood lamp? I don't know. Here we have vitiligo on a person's eyelids. And we have our wood lamp showcasing vitiligo that we really needed the wood lamp to see. Now, albinism, right? Albinism. Congenital absence of pigmentation caused by a tyrosine deficiency that hinders melanin formation is known as albinism. Like in this picture, this young girl with albinism who's just hanging out in Papua New Guinea. Albinism may involve the eyes, that's the ocular form, or both the skin and the eyes, which is the oculocutaneous form. Reduced ultraviolet B, UVB protection in albino patients increases the risk of squamous cell carcinoma, basal cell carcinoma, and melanoma. Here we have a young child with albinism. And here we have a prominent figure in Africa with albinism. Now, freckles. Freckles are also called aphilis by dermatologists. These are two patients or friends or people with innumerable freckles, or maybe technically they're numerable. You can count them. Freckles tend to be small, tan to brown macules. Freckles darken in the presence of sunlight due to an increase and melanosomes, but not melanocytes, right? It's the melanosomes that increase. Here we have a patient with freckles. Now, melasma. Melasma is a mask-like darkening of the cheeks. As you can see here in this picture to the right, with the melasma lesions circled in red. Melasma is associated with pregnancy and oral contraceptives. Here we have a doctor performing treatment for melasma with potassium titanophosphate laser, or a KTP laser. Now, nevus. A nevus is also known as a mole. Nevi is plural for nevus and are also known as moles. Nevi are benign neoplasms of melanocytes. Congenital nevus is present at birth, which is often associated with hair, and acquired nevus arises later in life. The most common mole in children, adjunctional nevi, start as nests of melanocytes at the dermal-epidermal junction. Compound nevus exists within the junction and the dermis. The most common mole in adults is an intradermal nevus, which develops when the junctional component eventually disappears. In general, nevi are characterized by a flat macule or raised papule with symmetry, sharp borders, evenly distributed color, and small diameter, less than 6 millimeters. And since we're on the subject, regarding melanocytic lesions, what does A, B, C, D, E mean? Asymmetry, yes. Border, color, diameter, evolving. Okay. Now, dysplasia may arise and may be called the dysplastic nevus, which is a precursor to melanoma. Here we have a picture of a specific type of nevus known as a nevus spillus. And here we have a nevus sebaceous, yes, that protuberant lesion with hair coming out of it is a type of nevus. And cryotherapy can be used to treat skin lesions. And here we have a Mongolian spot visible on the lower back of a 6-month-old patient. And here we have Becker's nevus on the right shoulder of a patient. And here we have nevus anemicus on the left leg of a patient. And here we have a café au lait birthmark on the left cheek of a patient with a dime from the United States of America next to it, just to indicate the scale. And here we have a dysplastic nevus. Note that it's somewhat large, has scalloped borders. It's a bit indistinct in areas. And here we have a compound nevus on a patient and a dermatoscope used by dermatopathologists or dermatologists to assess skin lesions. And here we have a panel of various normal moles. And here we have nevus of Ota before treatment, right? That nevus is affecting this patient's eye. And a dermoscope, if you haven't seen one of those, this is what it looks like. And a conjunctival nevus in a patient. And an intradermal melanocytic nevus, IDN, histologically. And here we have a picture of a congenital melanocytic nevus. and a pie chart showcasing the relative breakdown of pigmented skin lesions. As you can see, it also lets you know what's benign to more aggressive in the malignant category. This is a good image to have. And here we have a Spitz nevus, characteristic nevi in children. And another nevus that's typically present in children is a nevus flammus. Note that this is a birthmark, commonly known as a buzzword, stork bite or angel's kiss. Now, melanoma. This is very important. The malignant neoplasm of melanocytes is called melanoma. Now, to the right here, I want you to use your A, B, C, D, E's. Is it asymmetric? What about that border? Yeah. Color, is it uniform color, or does it have various portions that have different colors from one another? Different, right? How about the diameter? It's a bit strange, and we don't know if it's evolving or not because we have a picture. But yeah, this is melanoma until proven otherwise. Now, speaking of melanoma, this is regarded as the most prevalent reason for skin cancer fatalities. Risk factors for melanoma include xeroderma pigmentosum, albinism, Norwegian descent, chronic sun exposure, and risk factors are all based on UVB-induced DNA damage of the skin. Dysplastic nevus syndrome, an autosomal dominant condition marked by the development of dysplastic nevi that may lead to melanoma, is another risk factor. Melanoma can be differentiated from a nevus using the A, B, C, D mnemonic, as you are aware of. A for asymmetry, B for irregular borders, C for color, D for diameter more than 6 millimeters, and you know the extra E, evolving. Melanoma is characterized by two growth phases, either out or down, out for radial growth or wide, and vertical growth for depth. While vertical development penetrates the deep dermis, radial growth occurs along the epidermis and superficial dermis with little chance of metastasis. Melanoma has this is important, increased risk of metastasis. Depth of extension or Breslow thickness is the most important diagnostic prognostic factor in predicting metastasis of melanoma. Variants of melanoma include superficial spreading, lentigo maligna, nodular, and acral litiginous. The most prevalent subtype of melanoma, superficial spreading, is prominent in the early stages of radial expansion and has a favorable prognosis. Lentiginous proliferation with radial growth characterizes lentigo maligna melanoma, which has a favorable prognosis. The nodular variant of melanoma has early vertical development and shows poor prognosis. Now, the palms or soles of people with dark skin, African Americans, frequently develop acral lentiginous melanoma. And here we can see a diagram showing where melanoma is most likely to develop. And here, we're seeing this representative pie chart again. It must be important. Now here we have a picture of malignant melanoma occurring on a right posterior thigh in a patient. And look at this, a difference between melanoma and normal moles. That must be important. Now, this is the histology of melanoma. Can you see that melanocytic nest right about center there? Oh, and look at this melanoma that's metastasized to a lymph node, taken over. What do you need a dermatoscope for? Because you're a future dermatologist? I'm talking to you. Here we have melanoma involving the scalp of a patient marked for biopsy, and melanoma on the right forehead. Use your ABCDEs. Now this is histology. You can see in that superficial layer there. Now this is super obvious, super easy. Everyone should be able to see the nests of melanocytes. Note the pigment that are at the superficial layer, right? Classic melanoma histology right here. And this is a cartoon indicating the various stages of melanoma. TIS, T1, T2, T3, T4, all indicated by depth. And here we have malignant melanoma of a left forearm in a patient post-excision with purse string closure. Interesting. Now use your ABCDEs. And here we're utilizing a dermatoscope looking at a melanoma, specifically a superficial spreading melanoma in situ. More histology of a melanoma. Use your ABCDEs. Use your ABCDEs. Use your ABCDEs, right? Melanoma. Questionable, need to biopsy, but ABCDEs. Questionable, we'll biopsy it. The pathologist will let us know, right? Oh, now this one looks concerning if we're using our ABCDEs or ABCDs. We can't really tell if it's evolving from a picture, right? We need sequential pictures over time. Here we have malignant melanoma in situ of the left upper inner arm from a patient. Ooh, now this is melanoma of the anal canal, right? The anal melanoma. Obviously, status post-surgical removal of the anus and a portion of the rectum there. Wow. So here we have a large asymmetric dark brown macule, irregular border, concerning for melanoma. Yes, the acral lentiginous type of melanoma affecting the sole of the left foot. Utilizing a dermatoscope to visualize melanoma. And note the various lines on there to help gauge the size. That's very useful. And here we have a malignant melanoma in situ evolving medial right temple with adjacent sebaceous hyperplasia. Questionable melanoma, right? Questionable melanoma, use your ABCDs. Ooh, this is gross pathology of melanoma metastasis, which is a pigment forming in a vast majority of cases, giving it a dark appearance, right? So basically, the melanoma metastasized to somewhere. I can't really tell what tissue this is in even. Wow. And here we have classic histology for lentigo malignant melanoma. Malignant melanoma, utilizing a dermatoscope. Now this is questionable. Is this melasma or melanoma? Brown patch, somewhat large. Can't say just based off the image. It's a male, less likely to be melasma, but we'll need to biopsy it, right? Now this, even though the border isn't that concerning, it's somewhat of a well circumscribed oval, circle-ish. That very, very dark color on a Caucasian person, questionable. Definitely get a biopsy. Here we have malignant melanoma at the left mid-back marked for biopsy. And here we have various pictures of H&E from a melanoma, obvious melanoma, nodular melanoma type. Now, let's talk about infectious skin disorders, starting with impetigo. Impetigo is the superficial bacterial skin infection. Common causes of impetigo include Staphylococcus aureus and Streptococcus pyogenes. Impetigo typically presents on the face as erythematous macules that develop into pustules. When the pustules of impetigo rupture, the erosions dry and a honey crust is produced. Here we have a severe case of facial impetigo. Doesn't have the quite classic appearance of the honey-colored crust, but in real life, lots of conditions don't read the textbook. Here we have impetigo on the back of the neck of a patient. Okay, we have some honey-colored crusting there. And here we have bullous impetigo after the bulla have been broken. And here we have bullous impetigo on the arm with vesicles and bulla, right? Form of impetigo. Now, cellulitis. Cellulitis manifests as a red, tender, swollen rash with a fever and is a deeper dermal and subcutaneous infection. Risk factors for cellulitis include insect bites, trauma, recent surgery, scratching, and open wounds. To the right here, we can see a picture of a patient's left arm showing cellulitis following an abrasion. Note the red streaking up the arm from involvement by the lymphatic system. Common causes of cellulitis include Staphylococcus aureus and Streptococcus pyogenes, right? Those are big players. Due to an infection with anaerobic flesh-eating bacteria, cellulitis can progress to necrotizing fasciitis with necrosis of subcutaneous tissue. It's the production of carbon dioxide, CO2, that leads to crepitus and cellulitis. Cellulitis is a surgical emergency, right? You future emergency doctors will be seeing this. Here we have a picture of an infected left shin in comparison to the right side shin with no sign of symptoms in a patient with left lower extremity cellulitis. And here we have a picture of a patient with cellulitis of the left leg with foot involvement outlined there on the border, a common technique to see if it's going past the border or regressing from the border over time. Now, staphylococcal scalded skin syndrome. This is important. Shows up a lot. Staphylococcal scalded skin syndrome is characterized by skin sloughing, an erythematous rash, and fever. Staphylococcal scalded skin syndrome is due to exfoliative A and B toxins that cause epidermolysis of the stratum granulosum. Staphylococcus aureus produces exfoliative A and B toxins. That's important to remember. Staphylococcal scalded skin syndrome is distinguished histologically from toxic epidermal necrolysis by the level of skin separation. In 10, the separation is at the dermal-epidermal junction. In SSSS, the separation is at the stratum granulosum. Now warts, or verruca. Verrucas are also called warts, as you can see here on the bottom of this patient's feet. Verrucas are flesh-colored papules with a rough surface that develop after keratinocytes become infected with the HPV virus and are distinguished by coilocytic alteration. The hands, feet, and anogenital region are common locations for verruca. Here we can see a mosaic cluster of plantar warts with salicylic acid recently applied, right, to help treat them. And here we can see a deep plantar wart at the heel of a patient. It is so painful that the young patient was unable to put any weight on it. And here we have a 30-year-old patient with plantar wart. You see that there? And here we have young plantar warts in their very initial phases of growth. And here we have a large plantar wart. And here we have a verruca just behind the toes in the right foot of a patient. It's small. And here we have a plantar wart that was surgically removed next to a ruler. And cryotherapy being applied to a plantar wart, right, to treat them. You future family medicine doctors out there in the clinics, you'll probably be doing this. And IHC is not typically utilized for verruca. This is probably done in a research setting. Now, molluscum contagiosum. Molluscum contagiosum are hard, pink, umbilicated papules on the skin, as you can see here to the right. The pox virus, that's important to remember, the pox virus causes molluscum contagiosum. Cytoplasmic inclusions are visible in affected keratinocytes. Molluscum contagiosum are most commonly seen in children. Adults with molluscum contagiosum should be screened for immunocompromising issues like HIV. And with that, you completed another lecture to ensure that you know everything about pathology, everything that you need to know to succeed on step 1 in your medical coursework and in the future of medicine. I appreciate you listening. I hope this has been beneficial for you. I'm rooting for you. I know you're going to do the best. You're going to succeed, and I'm glad I could be part of your journey. I'll see you later. Take care.